Is this patient a candidate for ARNI? What can we do? Yes, in my opinion, will an introduction of ARNI reduce the need of device therapy in heart failure with reduced ejection fraction? Now, when you have the recommendations for implantable cardioverter defibrillator in patients with heart failure, these are recommended in patients to reduce the risk of sudden cardiac death or all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability and who are expected to survive for just less than 1 year. Now, if more than 1 year with good functional status. So, an ICD is recommended in these individuals, and an ICD is also recommended for primary prevention to reduce the risk of cardiac death and all-cause mortality in patients with symptomatic heart failure, that is NYHA 2 or 3, and an LV ejection fraction of 35%, and who have had a more than 3 months period of optimal medical treatment, provided they are expected to survive for more than 1 year with a good functional class. So these are the indications for an ICD. Now, there is a gap in evidence. There's long-term data on tolerability and compliance of ARNI in real-world scenarios, which is still not available. But in my opinion, it is very important that if you can introduce ARNI for these patients, maybe they might prevent, you can prevent ventricular tachycardia to an extent of around 20% of these patients. So, implantable cardioverter defibrillators, yes, you can, these are patients who require these devices, you can start ARNI. It is not a substitute for ICD or CRT, definitely not. But having an ARNI on board can prevent sudden cardiac death to almost to the tune of 20% in patients with LV ejection fraction less than 35%.